Hello, everyone, and welcome to today's keynote webinar titled History and Future of Tier 1 Genomic Population Screening. This webinar is part of the 12th Annual Precision Medicine, Genomics, Genetics, and Molecular Diagnostics Virtual Event Series. I am Kaylee Bach of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots. Before we begin, I would like to remind everyone that this event is interactive. We encourage you first to participate by communicating with other attendees using our live chat feature during the presentation. You can find the live chat located at the bottom left of your screen. You can also participate by submitting as many questions as you would like during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, click on the Help Desk button from the lobby within the event. And finally, as a reminder, this presentation is educational and offers free continuing education credits. Click on the Continuing Education Credits image located on the right of your screen and follow the process to obtain your credits. All right, now let's get started. With that, I'd like to present today's speaker, Robert Green, Professor of Medicine, Harvard Medical School and Mass General Brigham, co-founder Nurture Genomics. For a complete biography on our speaker, please find it on the left of your screen. Robert, thank you for joining us. You may now begin your presentation.
Thank you so much, and hi everybody. For those people who caught the last lecture I did here, this is different but complementary. As you know, I've been really interested in population screening, so-called DNA first. I've been interested in it from a number of angles. I've been interested in it from a return of research results in large-scale sequencing studies. Remember, there's over 100 million people worldwide who've had some form of research sequencing, and almost none of them have had anything medically relevant returned to them. I've been interested in it from the angle of secondary findings. For example, I helped create the ACMG secondary findings list in 2013, which has now grown to version 3.2 from 56 genes originally to I think about 81 genes now. And I'm interested in simply what would the world be like if anyone who wanted it could get screened for DNA, could get their DNA screened for risk stratification, either as an adult or as a child. And many of you know that I've essentially worked on randomized clinical trials called the MedSeq Project for adults, in whom we did comprehensive genomic screening, looking at 5,000 or so genes. Found remarkable findings that about 20% of those apparently healthy adults were carrying monogenic risk variants. And then for the last 10 years, we've led the world in sequencing apparently healthy newborns and infants in the BabySeq Project, which is the world's first project to sequence babies comprehensively. And looking at 1,000 genes or so, we found that 10 or 11% of those apparently healthy babies were carrying a monogenic disease risk. And we already discovered that some of them were underdiagnosed or misdiagnosed. So that's the background work that I've been doing. And if you're interested in that, please check out the other LabRoots talk I did or other talks on our website, which is Genomes2People.org. But today, I'm actually going to drill down into something that's gaining a lot of traction nationwide in the United States, which is a sort of grudging acceptance that genomic screening can be a good thing, and a sort of, all right, what's the absolute minimum we could start with? And we might be a healthcare system, we might be an employer, we might be a return of results from research initiative. And in search of that sort of absolute minimum, many folks have reached for the so-called CDC Tier 1 conditions. And as you're going to hear, that is typically 3 sets of conditions and about 9 or 10 or 11 genes. I'm going to explain the history of this and talk a little bit. It's such an interesting history, sort of full of almost like a detective story, full of twists and turns. And I thought it'd be a really interesting story to share with you. I don't have a slide on my potential conflicts of interest, but I do like to tell everyone for every talk that I receive compensation for advising the following companies: Allelica, Atria, Fabric, Genomic Life, and Juniper Genomics. And I am a co-founder of 2 startup companies. One is Genome Medical, the 50-state telemedicine genetics testing and clinical service company, and Nurture Genomics, a brand new startup that's just come out of stealth, which will commercialize newborn and childhood sequencing. So those are my industry potential conflicts of interest, so you know those. So let's jump right in, and I hope you'll find this story as interesting as I do. Remember that there is a long-standing and ongoing debate about population screening with any kind of diagnostic or risk stratifying technology, which is very relevant to genomics. And that is that it's an obvious potential benefit, right? If you know somebody has a cancer predisposition gene, if you know that they have a sudden cardiac death gene, you can interpret symptoms in a different way when they have symptoms, and you can take surveillance efforts or actual interventions to try to save their life. An obvious example of this would be if somebody has a Lynch syndrome mutation for colorectal cancer, you can accelerate the start and the frequency of colonoscopy, and you can find and prevent cancers. So the benefit is sort of obvious, and we know that there are lives being saved every day through this. We also know from many, many different types of surveys from all sorts of different angles that both patients and research participants say that they want to know this information. Almost across the board, no matter how you ask the question, no matter what kind of survey it is, about 70% of people say that they would like to hear about their own genetic information if it's something treatable. Pardon me. And they would, even about 40 to 50% say they'd want to know about their own genomic risk information, even if it's not treatable. So there is a powerful and consistent sense that people in general want to know about this. So why isn't it done? Why isn't it obvious? Why isn't your doctor saying to you when they first establish a practice with you or with your children, let's get your genome done, or let's get a certain panel of genes done to screen you? And as many of you know, the debate hinges around the question of clinical utility. How truly clinically useful will it turn out to be if you tried to screen a population of 1 million people? Is this cost effective? Is there a sufficient workforce in place to manage the results that come out? Are you going to do some sort of harm to people, either psychologically or through downstream medical follow-up that wasn't necessary? So this debate goes on, and it goes on today, and it's been going on for 50 years, really, in one form or other, as we have evaluated different ways of screening the population. Now, the story of the so-called CDC Tier 1 conditions actually begins in the 1990s, when the then director of the CDC, David Satcher, decided that the CDC should have something going on in genetics. And so first, as government types often do, appointed a task force to propose a strategic plan. And sure enough, in 1997, the Office of Public Health Genomics was established. And Mew and Curry was PhD genetic epidemiologist, was placed at the leadership of it and leads it to this day. So what did they do? Well, they did. They worked on essentially what should they do, and then after the first couple of years, they decided to create an initiative they called EGAP, or Evaluation of Genomic Applications in Practice and Prevention, to evaluate gene by gene what the evidence was for essentially public health use. And they created this ACCE structure, clinical, C for clinical utility, C for clinical validity, A for analytic validity, and E for ethical, legal, social implications. And this became a very common framework for thinking about genomics in the 1990s and the early 2000s. You were supposed to think about first, was there analytic validity? Were we able to accurately measure the mutation, which has become something of a non-issue? Was there clinical validity? Was the gene and the specific variant specifically associated with the illness? Obviously, for something like BRCA1, it obviously is. For some genes, it's a little more dicey. Was there clinical utility? Did we have any real rigorous proof that finding that mutation early or finding it at all made for better health outcomes? And finally, along the whole thing, we should think about the ethical, legal, and social implications, or ELSI. So this framework was incredibly influential, but it was also very slow. I participated in some of these early meetings, and I was really thinking, this can't work in the long run. You can't spend 6 weeks or 6 months on a single gene and hope to keep pace with and sure enough, this implementation framework sort of lost traction as sequencing became more and more ubiquitous and faster and less expensive and more clinically useful. In September of 2005, the U.S. Preventive Services Task Force did recommend genetic counseling, which is, of course, a different group, did recommend genetic counseling and possible genetic testing for women at high risk for BRCA1 and 2, meaning that they had a specific family history pattern or had a relative who tested positive. This was not, and to this day, they do not recommend population screening of any way, shape, or form. And this was the first ever USPSTF recommendation for genetic screening. But the sort of chilling words that are still there was, quote, "for most women, testing is not recommended." So it was a very specific use case. And this sort of mentality permeated clinical genetics, which is that genetic testing is expensive and it's problematic and it has a lot of risks associated with psychological distress and potential privacy and discrimination. So we should really, really reserve it for those people who are at the highest risk by virtue of their family history or a known relative. And this mentality continues to permeate genetics, and I think to the detriment and has been an obstacle to a more universalistic approach. Now, around the same time, in the UK, the National Institute for Health and Clinical Excellence recommended similar types of testing for familial hypercholesterolemia, again, only for people who had very early heart disease or prominent family history or already knew they had a family member with a mutation. And then around that same time, the EGAP working group jumped in and made a similar recommendation for colorectal cancer. All of these recommendations now were starting to emerge, but only in these circumstances I've described. One of the earliest papers that got a lot of traction, I remember reading this paper and really being super impressed by it, by Jonathan Berg, Mullen, and Jim Evans, was an attempt to sort of prioritize bins, and they were prioritizing these bins. You can see using some of this same language: clinical utility, clinical validity, and then sort of other types of genes which had unknown clinical implications. And they've got on here, you can see in their so-called bin 1, they've got BRCA1 and 2. They've got some genes for Lynch syndrome, FBN1 snuck in there, NF1 for neurofibromatosis, a couple of things snuck in there. Feels a little arbitrary. And then suddenly they skipped over to pharmacogenomic variants in bin 2A. And carrier status in bin 2B, and then things that almost nobody says they want, Huntington disease in what they call bin 2C. So I think this was more of a proof of concept. And back at the CDC, Ewan organized a very important meeting on September 7th of 2012, where he convened about 80 stakeholders in Atlanta. I was not at that meeting, but this was the meeting in which this group endorsed not a specific set of genes, and even to this day, not a specific set of genes, but a set of conditions. And those conditions were breast and ovarian cancer predisposition, Lynch syndrome, and familial hypercholesterolemia. It's funny to name a condition after a gene, right? But that's the way BRCA historically conflated naming the gene and naming the condition. So that just is a historical sort of quirk. Again, this tier 1 designation was explicitly oriented toward individuals either with disease, you're an individual with early heart disease, or with young breast cancer, or with early colorectal cancer, or an individual who had a big family history, or somebody in the family who already had a testing. Now, we'd call this a no-brainer today, right? We'd say, well, of course, if I have a sister with BRCA1, I am eligible to be tested for BRCA1. If I have two brothers who had heart attacks in their 40s, maybe we'd want to test them to see, or maybe even me, to see if we're carrying an FH gene, especially if my lipid levels are high. So this kind of feels obvious, but that's what they were talking about. They weren't talking about population screening. And so around this tier 1 designation, they created a whole tier 1 toolkit. You'll see that back before he was famous, Tom Frieden actually was involved in creating this toolkit. And there was a whole sense that we needed to educate the public, we needed to educate clinicians, we needed to think about socioeconomic factors, we needed to understand what's the societal context. And so there was a whole back end to this, which was very laudable, but also kind of further exceptionalized the idea of genetics. As you know from my prior talks and just from themes in our field together, many of us have argued that genetics is wrongly exceptionalized or over-exceptionalized, and that we could benefit from treating genetic testing just like we treat other types of testing, and a little bit less exceptionalistically. But this whole intellectual infrastructure here kind of reinforced the exceptionalism. One of the next things that happened historically was that I was involved in was, oops, sorry, I went to push the wrong button there. There we go. One of the next things that I was historically involved in was in about 2011. I was really interested in this and joined with Jonathan and some of these other folks that you've been hearing about, plus all the leaders I could find. And we created a concordance-discordance matrix for the return of secondary findings. In other words, we simply asked each person would you return this gene? Would you return that gene? And we actually ended up creating a ranked list. And because I published that, they asked me to co-lead the working group for the American College of Medical Genetics and Genomics, which I asked Les Biesecker to co-lead with me. And together we created the first ACMG list in 2013. And as you may know, that first list had 56 genes. They were mostly inherited cancer disorders and cardiac disorders and a few others. And the notion here was almost super simplistic. If you getting a genome for any reason, what would we also like to look for? What could we not sleep at night if we didn't tell you about? And it became clear through our conversations that we might disagree on a few of the edge cases, but we all agreed that if there was a chance to look for a BRCA1 or an FH or any of these 56 genes, we really ought to look for them. And that launched in 2013. It was amazingly controversial. A whole lot of people pushed back on it. The whole right not to know turned it from our original conceptualization of a required secondary finding exercise to at least an opt-out. So by default, all labs in America we recommended should do this when they sequence. And by and large, most have, and it stood the test of time. There's now a version 3.2 that's come out with about 81 genes. And it's way less controversial than it was when we launched. So I'm very pleased that to this day, this is the only official recommendation in the world that I'm aware of that says what you should return. And it's become the basis for a lot of IRBs who are trying to decide what to suggest their investigators return in research. As you may know, the version 2 with 59 genes became the basis for return of results in the 1,000,000-person All of Us research study. So very proud of this. And this was happening now around 2012, 2013. A few years later, some of our colleagues, including Muin again, sort of said, maybe we should be thinking about population screening after all. Like, maybe we should really be thinking about this. And these are more speculative articles. They weren't demanding it. They weren't sort of arguing for it, but they were thinking about the kind of approaches. And in those articles, they started referring to the tier 1 conditions. Now, however, they're referring to them in a new way. The CDC never suggested and never promoted these conditions for population screening. But when Mike Murray wrote this article up here, and then Mike and Jim and Muin wrote a follow-up viewpoint, basically making the same points, they cited these conditions as natural first steps for anybody considering population screening. They still hedged their bets, though. So, here's this JAMA viewpoint where they wrote, however, many questions need to be answered before commencing with routine population-based screening. They just weren't willing to all out suggest it. Meanwhile, the folks, David Ledbetter, Mark Williams, Amy Strum, Adam Buchanan, and a host of folks at Geisinger were leading the country and the world in terms of an arrangement with Regeneron for a large biobank sequencing exercise. And here this, central Pennsylvania vertically integrated healthcare system without, obvious academic connections suddenly started publishing the coolest papers in the world that applied on this issue. So, for example, this paper in 2020 found that if you looked at the so-called conditions, that they found that quite a large percentage of these folks that they were finding with so-called tier 1 results. And really importantly, 87% of the people that they found with a mutation for one of these tier 1 results had not been previously diagnosed with that mutation, had not been tested. Some of them met family history criteria, some of them didn't. And so the criteria by which we have traditionally been saying, let's test those people, is just bad. It's wrong. It misses tons and tons of these people. If it's valuable to find them, we're doing a terrible job at finding them. Another paper came out in 2020 with the Healthy Nevada people and Helix people looking at the same question. And they found a 1.3% carrier rate. And 90% of those had not previously been identified as mutation carriers. So, wow. I mean, think about that. If you think this is important to know, 90%, 87% of Geisinger, 90% in Nevada are not getting identified by traditional medical means. So this obviously argues in favor of some kind of population screening. A further paper a few years later looked at very, very similar types of results in South Carolina. Finally, the American College of Medical Genetics in 2021 issued 2 statements, position statements. Now, these were not recommendations. They were what's called points to consider, meaning we're not sure enough to make a recommendation, but we think you ought to think about these things. And weirdly, we had 2 groups. And Mike led one group, which sort of leaned into the tier 1 conditions. And Laura and Cynthia Powell led the other group, which both Les and I were on, and perhaps in part because of our influence, it ended up leaning a little more into the idea that the ACMG secondary findings might be salient to this. So the lists were somewhat different. They didn't end up recommending population screening, but they kind of grudgingly said, well, if a patient really wants this and you do genetic counseling and you kind of warn them of all the things they might find, I guess it's okay. So it was really damning with faint praise. And then very interesting, and most recently in 23 and 24, some modeling has come out of cost effectiveness for population screening using these conditions. And these are fascinating papers. If you get a chance, if you're interested in cost effectiveness and you get a chance to read them, they come up with very different results because in Australia, costs are different and there were different assumptions. So I don't know, which one is right, but somewhere between $15,000 US and 68,000 or US dollars, there seems to be per quality adjusted life year, there seems to be an agreement that you're not going to save money by population screening, but you could save lives with it at this kind of cost. And these costs are underneath the thresholds in both countries for what is usually considered acceptable for adoption. And so that's encouraging, but not definitive. Moreover, when you talk about, remember I said that these were conditions and not genes. It turns out, just to make the plot a little thicker, it turns out that when Mike wrote his papers, he was envisioning a list of 10 genes for the 3 conditions. As you can see there, it did not include PALB2. When Adam and the Healthy Nevada folks wrote their papers, it was 9 genes, didn't include PALB2 or EpCAM. And when Paul Lacaze in Australia is doing a big nationwide study now of screening, He included PALB2, but didn't include PMS2 or EpCAM. So the so-called tier 1 is actually 3 different lists. You get to pick, you sort of get to pick your favorite, and different people have different reasons for including various ones. Just a reminder for those of you who don't, eat, sleep, and breathe this, that there are 20,000 or so total genes. There are about 10,000 genes linked to human disease. About 7,000 of those are strongly and linked with very good evidence to human disease, so we really believe them. And so you have a lot to choose from when you're thinking about some kind of screening product. You can think about 1 gene, just FH, or 2 genes, just BRCA1 and BRCA2. You can think about the 9 to 11 genes on these tier 1 conditions, or you could think about going higher, like we've done in some of our research studies. So this is really, if you believe these data and you sort of take home this concept, I think this is probably the most important concept I'm talking about today, which is what you find in a population depends on how many genes you test. Now, if you think about that, it's pretty obvious, but we don't tend to think about it this way very often. So we are reliably getting between 1% and 2% of folks carrying pathogenic and likely pathogenic variants if you look at these sort of 9 to 11 genes in the so-called CDC-10 or CDC Tier 1. In the version 2 of the ACMG list, the 59 gene, we got a lot of population data out of that. Very reliably 2.7% of folks. And the version 3, it's still a little unclear, but probably between 4 to 5%. The Invitae Health Screen, which was 147 genes and has gone up to 167 genes, we published a paper with them that suggests that about 6.2% of the population will have a positive. And in our MedSeq, BabySeq, and MilSeq research studies, where we've looked at anywhere between 1,000 and 5,000 genes, we find anywhere between 10 and 20% follow-up. And we've verified this, and this has been validated in other groups. After we did ours, Mike Snyder's group found this, Craig Venter's HLI group found this, and others have reported this as well. So that's a lot of people carrying monogenic disease risk. So I kind of want to summarize here, wrap up, and I'm hoping there'll be some interesting discussion and debate. Very curious to hear your thoughts on this, if you'd like to share them. But the summary and take-home points are that the so-called Tier 1 conditions have sometimes been conflated with the message, somehow the CDC has recommended population screening with these genes. They have not. They have not to this day. Neither has the U.S. Preventive Services Task Force, neither has the American College of Medical Genetics, neither has anyone else. Although a lot of it's going on in research studies and in employer-based opportunities and some healthcare systems and even nationwide studies like in Australia, no one has recommended this. As an aside, I think we're about to see a real sea change in policy in the UK, as one of the investigators there has convinced the UK government to population screen for BRCA1 and 2 sequencing in families of Jewish descent. They're self-described. And of course, the country of Israel has been doing a fair amount of this for a long time, but really nobody else. Then pathogenic variants in these genes are found in 1% to 2% of the general population. Of course, ascertainment bias is going to play a role here. If you send out a call and you say, hey, would anybody like to get their genome sequenced for risk of family diseases, particularly family cancers. The kind of people who are going to volunteer for that are information seekers, proactive folks who believe they won't be too upset if they get positive, but also people who maybe secretly suspect that this is running in their family. So that could increase the percentage. Also, because some of the founder mutations in BRCA1 and 2 are really quite common, the more a population you're screening happens to have an Ashkenazi background, the higher that rate will probably be. So there's a couple of variables that affect that. In our own Mass General Brigham Biobank, we looked for these, and we found that you heard the numbers before, 90%, 87%. We found that even in our tertiary care healthcare system in Boston, that 50 to 80% of those with pathogenic variants were not known prior to genetic testing. And as we said, in the general population, this can be 90%. That feels really wrong to me. It feels like we're really missing an opportunity to help these folks, at least the ones who want it. We've over-indexed on the right not to know and tiptoed around this and exceptionalized genomics. And I mean, where else could we spend, I don't know, about $300 today, look for mutations in those 9 to 11 genes, and in 1 to 2% of the population literally save their lives with an intervention? And we don't do it, right? I mean, and then cost effectiveness modeling sounds like that whatever the number is, it's below the threshold that most countries require for incorporation into their public health issues. So the question I ask often at the beginning of my talks, and I'll ask you here at the end of this one, is why aren't we doing this? Why isn't it happening? Why aren't you demanding it? Why aren't our policymakers demanding it? Why aren't our employer health system demanding it? And I think you know the obvious answers. We can discuss some of them in the discussion. I want to thank you for the opportunity to chat with you and remind you that all of our research projects and all of our publications are available at our website, Genomes2People.org. We'd love for you to follow us on any of the social media platforms there. And if I can be helpful, or you are interested in a training opportunity or a research collaboration with our group, that's my email right there. So with that, Kaylee, I'll wrap up my formal remarks and hope that maybe there are some interesting conversations to be had in the remaining time.
Great. Well, thank you so much, Robert. And yes, there are absolutely some great questions coming in here. So to our audience, we will now start the Q&A portion of the webinar. If you do have a question that you'd like to ask, please do so now. Just submit a question in the Ask a Question box located at the bottom of your screen. All right, so let's get started. Robert, our first question here asks, how can advances in genomic technologies, data analytics, and artificial intelligence contribute to enhancing the accuracy, efficiency, and scalability of Tier 1 genomic population screening programs?
Yeah, it's a great question. And as the questioner implies, I think the more we could automate, the more we could use, particularly curation, automation of curation, the more we could use AI to integrate literature searches, clinical decision support into existing medical record systems, the faster this could, and easier and cheaper this would be to adopt. I will say that in screening, most of us have agreed that we should return pathogenic and likely pathogenic variants, if you're familiar with these categorizations, and not variants of uncertain significance. And that actually simplifies the screening process because it's sometimes the VUSs, variants of uncertain significance, that take a lot of time and a lot of extra effort in the laboratory and slow things down. So if you're imagining a world in which this is automated, I think all those things the questioner mentioned will contribute to that automation, to driving the cost down and making it simpler for uptake. Yeah.
Great, thank you. All right, another question I have for you here. How is it useful in family resemblances screening genetically?
Sorry, say again, family resemblance?
Yes, the question asks, how is it useful in family resemblances screening genetically?
Yeah, I'm not sure what the questioner means by family resemblances. Maybe they're talking about family history, which of course increases the prior probability. If I have a first-degree relative with an early onset of one of these conditions, that increases the prior probability. As most of you may know, in such a situation, if the index case, the person with the early history of cancer or the early history of heart attack, is still living, you would typically, best practice would be go to them first and do a genetic test. But if they're not living, sometimes the presence of a family history can means that you would prioritize screening in that person. I don't think the questioner is talking about family appearance, physical appearance, if they're talking about family history, that would be my response.
Great, thank you. All right, moving on here. What ethical, legal, and social considerations need to be taken into account when implementing Tier 1 genomic population screening, particularly regarding issues of informed consent, privacy, and equity?
Great question. First, let me say that these are really important issues, and I don't mean to trivialize them or dismiss them. However, this is part of the exceptionalization of genomics. We don't ask this question about checking people's blood pressure. We don't ask this question about if you fall off your bike and you get an X-ray. We don't, and you might find a secondary finding. We don't ask this question about routine blood work. So I think a meta question, if you will, is this the right question to be asking about population screening, particularly of a limited number of what appear to be very useful, potentially life-saving genes? Or is the focus on questions like this part of what has delayed us and obstructed us from bringing this life-saving benefit to people? So I think we should think about that. I think we've over-indexed on LC issues and under-indexed on medical benefit. But having said that, any new technology, often gets its start without payer reimbursement, which means that it's often available for people with resources before it's available for people without. We know that underrepresented groups are both less commonly represented in reference biobanks, reference data banks. But that's very relevant to the polygenic risk space, but I think less relevant to the monogenic space, particularly if you're excluding VUSs. If there's a sort of sophisticated molecular people in the audience, you know that what's likely to happen in a diagnostic scenario is that you get far more VUSs in people, for example, with African ancestries, because of the variation, the genomic variation there. But if you're screening for known pathogenic and likely pathogenic variants, you are, I don't think you're as subject to differences on the basis of ancestry similarities and dissimilarities. So there are always the LC issues of potential discrimination, potential privacy violations. Again, we haven't let that stop us in psychiatric care. We haven't let that stop us in HIV testing. So I would argue that while we never want to be cavalier about those issues, we should really lean into the potential life-saving benefits. Sorry, kind of a long-winded response, but that it's important to ask whether we're fairly prioritizing for the benefit of all.
Absolutely. Thank you, Robert. All right, it looks like we have time for one more question here. And this question is asking if you can share your thoughts on the impact of non-US sequencing efforts in the area.
Sure. There are portions of the United States, particularly on the West Coast and the concierge medicine environment, in the entrepreneurial environments, ecosystem, that are like, why are we even having this discussion? This is so obviously beneficial. We should be doing it tomorrow. And so when I talk about this, it's like a Rorschach. When you talk to some of those populations, they're like, this is old. Talk to me about microbiome, multi-omics, epigenetics. I'm over genome. That everybody should be having that. And so a lot of them have, through private practices, gotten genomic screening. But in United States Preventive Services Task Force, when I talk to members on that committee, they're like, nope, not enough evidence for us to officially recommend it, and we're not going to. And that dynamic is playing out really all over the world. There are conservative, academically oriented epidemiologists and public health leaders who see this as a kind of Pandora's box that could be opened, and much mischief could take place. Laboratories could do this for profit, and they could do a bad job of variant classification, and they could identify people who are not actually at risk, and they could send them down the road. In the worst case scenario, they could send them down the road to mastectomies and oophorectomies when they didn't need to do them. So there's concern in the conservative circles around that. There's also in parts of the world where healthcare is more naturally out of pocket. Lots of Asia and Southeast Asia. It's like, hey, if you want to pay for this, go for it. And companies are springing up to provide these services and products. So it's a kind of a Wild West out there. And we might, my colleagues sometimes look at that and say, oh my gosh, there's so much potential for harm here. And there is some, but I also think this is a transitional period where quality shakes out. The checks and balances on quality get applied. In the United States, if somebody does this poorly, eventually they'll get sued. Laboratories are under increasing pressure to standardize. You may have heard just a week or so ago, the FDA came out with new regulations about laboratory developed tests that will affect the quality of all. They think that will improve the quality of all molecular laboratories. I think personally it's the wrong way to go about it, but so there are all these forces at play: commercial forces, conservative evidence-based forces, market forces, the focus on longevity and quality of life, the focus on omics in general, investors. Anyway, all these forces are swirling around both in the United States and internationally. And so it's a very exciting time. You have companies that just want to skip over the landlines, skip over sort of investing in diagnostic genetics as deeply, and simply want to sequence every child born in the Middle East. A couple of countries are focusing on that. You have countries like Estonia that, at least on paper, have a vision of sequencing every citizen. You have countries like Iceland, where enough people have been sequenced that you can infer who's carrying dangerous mutations throughout the entire country. And huge battles are underway as to whether it's right to reach out to them and call them up and tell them, we think you're carrying a cancer predisposition gene. And So it's a wonderful, exciting, wildly divergent and an interesting time. So I think it's a great question to end on, because we don't know what the future is going to show. I think it would be a shame if we get set back, if population screening can't find its way responsibly in the world in the next few years. I think it's a wasted opportunity to reduce pain and suffering and actually save lives in the United States and around the world. So I'll end with that.
Thank you so much, Robert. Do you have any final comments for our audience before we go?
No, I think for those who are interested, consider ways to get your own genome sequenced for a panel like this. I have no link to Invitae, but Invitae has a really interesting, fairly inexpensive panel of 167 genes, which is a very nice way to do a sort of top tier. It includes those tier 1 and a bunch of others. If you're a clinician, think about that in your practice. Even if people have to pay for it out of pocket, it's just a couple $100. So I think get into this as much as you can and grapple with it. And then I think that will help us move the ball forward.
Well, thank you again, Robert Green, for your time today and your important research. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period, will be addressed by our speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand for 1 year until May 15th, 2025. Labyrinths will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. So until next time, take care, everyone. Goodbye.